Hi, I'm Richard. I'm a speech and language therapist and a lecturer based in the UK. In today's video, I'm going to provide a step-by-step guide how I critically appraised a case study using the JBI Case Report Checklist. I will be critically appraising resolution of stuttering during ketamine treatment, a case report, which was written by Dan Bolton et al. And published in the Journal of Medical Case Reports. In this case report, the authors describe how a patient suffering with depression was given the drug ketamine and it resolved her stammer. I hope this video will be useful to students learning how to critically appraise literature, practicing clinicians, and members of the public interested to know how healthcare professionals evaluate different kinds of evidence. Let's start with a brief definition of what critical appraisal is. Critical appraisal is the systematic evaluation of research to assess its usefulness and validity to a given context. A critical appraisal checklist is a tool used to help readers with this evaluation process. Each checklist contains a set of questions designed to prompt the reader to look for certain information in the research. The number and kind of questions in a checklist depend upon the kind of study you are reading. The case reports checklist used today is published by JBI. This checklist asks 8 questions and asks the reader to rate each question yes, no, unclear, or not applicable. I will now go through each of these 8 questions in turn and attempt to answer them. The JBI appraisal checklist asks whether the patient's demographic characteristics are clearly described. This includes their age, sex, race, medical history, diagnosis, prognosis, previous treatments, past and current diagnostic test results, and medications. The current setting and context may also be described, so there's a lot to cover. The patient's age, sex, race, and diagnosis are listed in the case presentation section of the abstract. She is a 60-year-old white, non-Hispanic woman with a developmental stutter, also referred to as a stammer in the UK. Her medical history is described in the second column on page 2. She suffered from chronic lung disease and stage 4 chronic kidney disease. Her prognosis is more complex. The authors write that she died 1 month after beginning treatment, though they did not explicitly say what the cause of her death was. For the purposes of this case study, it is safe to assume that the cause was unlikely to be related to her stammer, being depressed, or the ketamine used to treat her depression. It is far more likely to be one of the physical health conditions mentioned above. Her previous medical and speech and language therapy treatments are described on pages 2 and 3. I will discuss these further in the next question. There was no mention of any past or current diagnostic test results, though there was reference to physical examinations being completed by a nurse in consultation with a treating doctor, focusing on vital signs, efficacy of pain relief, diet, and overall comfort on page 2. Her current medications were listed on pages 2 and 3. She took a wide range of drugs which will be discussed further in the next question. Finally, the setting and current context is described briefly on page 2, where it is explained that she was in a hospice. So for question 1 on the checklist, I would say yes, the patient's demographic characteristics are clearly described. The checklist suggests that a good patient history clearly describes the history of the patient, their medical, family, and psychosocial history, as well as relevant past interventions and their outcomes. In terms of her stammering history, in the first column on page 2, the authors describe how the patient stammered most of her life, beginning in childhood. They suggest there was no evidence to believe that the cause of her stammering was neurogenic or psychogenic in nature. In the second column, it mentions that her father also had a developmental stammer, which resolved spontaneously in his 20s, which provides further evidence for the cause of her stammer being developmental in nature, as there is a strong genetic element to the condition. In terms of her psychosocial history, in the first column on page 3, the authors provide information about the impact of her stammer. They suggest that the stammer took a significant toll on her personal and professional life. In terms of past interventions, in the first column on page 2, the authors describe how the patient received speech and language therapy in elementary school, but did not receive it continuously. She received further therapy in her 20s whilst at university, then again in her 30s, 40s, and 50s. They reported that the patient sometimes experienced improvement in her stammering following speech and language therapy, but the improvement was not permanent. In the first column on page 3, the authors explain that she stopped attending speech and language therapy in her 50s because she was not seeing progress with her speech. Her last block of therapy was approximately 2 years before she was admitted to the hospice. Essentially, the timeline of events for the main treatment of the case study being used is not clear. There was also limited information given about the psychosocial impact of her stammer and what this meant in terms of practical consequences. The authors describe how her stammer took a significant toll on her personal and professional life, but did not explain this in any detail. For example, was she single or did she have a history of failed relationships? Did she not have children and felt her stammer contributed negatively towards this? Likewise, was she unemployed or underemployed? Then there are references to her attending university and having frequent contact with family and close friends, which suggests some success in some aspects of her life, which complicate this picture even further. Again, the specific impact of her stammer is unclear, which is important context to have in terms of understanding why she discontinued speech and language therapy and why she was so happy after the ketamine treatment. There was also no explicit explanation given for her death. The checklist suggests that the current clinical condition of the patient should be described in detail, including the uniqueness of the condition or disease, the symptoms, frequency and severity. The case report should also present whether differential diagnosis was considered. The current condition of her stammer prior to treatment was not described. This is not surprising given the developmental nature of her stammer and the unexpected nature of the change in her presentation. We learn from question 2 that the authors attempted to seek historical records of her previous stammering, but this request was refused unfortunately. So for question 3 in the checklist, I would say no, the current condition of the patient on presentation was not clearly described. The checklist suggests that the case report should provide sufficient information to understand how the patient was assessed and diagnosed. This might involve including which diagnostic tests were ordered and providing photographs or illustrations of procedures, etc. We learn from question 3 that no assessment of the patient's stammer had been completed on presentation. So for question 4 on the checklist, I would say not applicable. No diagnostic tests or assessments were conducted, so there was nothing to report upon. The checklist suggests that it is important to clearly describe the treatment or intervention procedure so other clinicians can have a clear understanding of the treatment protocol. In the second column on page 2, the authors describe that the patient was prescribed ketamine 5 months after her admission to the hospice for depression. She was prescribed 2.5 milligrams twice daily. She took this continuously for 1 month until she unfortunately died. So for question 5 on the checklist, I would say yes, the intervention was clearly described. The authors did not state the route of administration for ketamine, which is a relatively minor omission and would not likely have an impact upon other clinicians attempting to replicate the treatment. The checklist suggests that a good case report clearly describes the clinical condition post-intervention in terms of the presence or lack of symptoms. The authors make several references to the patient's post-intervention clinical condition. In the title of the case study, they write that her stammer resolved. In the abstract, they suggest that she experienced an almost immediate resolution of her stammering. On page 2, they suggest that she stopped stammering, that within 24 hours of beginning ketamine treatment, she experienced a resolution of her stammering. They mention that her family and close friends noticed and commented upon the change in her stammering immediately. They suggest that her stammer resolved and her mood improved considerably, possibly due to a combination of the ketamine and her newly fluent speech. On page 3, they suggest that the impact of the ketamine was substantial. She could consistently speak freely for the first time since early childhood and now communicated with ease. In the last column, they suggest the drug enabled her for the first time in decades to communicate through speech without impediment. It is clear from these descriptions that there was likely some change in her presentation. However, the authors also describe in the second column on page 2 that there was some limited breakthrough stammering in the form of repetitions but no blocks in her speech. Given that repetitions are symptoms of stammering, it is misleading to suggest that her stammer resolved as they do. So for question 6 on the checklist, I would say unclear. The authors describe the post-intervention clinical condition, but they do not do this clearly and sometimes are misleading in their description. The checklist suggests that any adverse events or unanticipated events are clearly documented and described. The case study did not report any adverse events after the patient took the ketamine. The fact the patient died would not be considered an adverse event, as she likely died from one of her other medical conditions. The resolution of her stammer is an unanticipated event, as there are no previously published reports suggesting ketamine as a treatment for stammering, and it was originally prescribed to treat her depression. So for question 7 on the checklist, I would say yes, adverse events or unanticipated events were identified and described. The checklist suggests that there should be a summary of key lessons learned from the case in terms of background of the condition or disease and clinical practice guidance for clinicians when presented with similar cases in the future. In the second column on page 3, the authors suggested that this case study extends the existing literature by identifying a new medication that affected a patient's stammering. There had been no previously reported cases of ketamine affecting stammering, so further research on it as a possible treatment would be valuable and could lead to improved outcomes for people who stammer. There was also a smaller takeaway lesson mentioned before this in the first column. The authors suggested it would be wise to screen patients who stutter for depression as part of their care because of the potential link between ketamine as a treatment for depression and a possible effect on stammering. So for question 8 on the checklist, I would say yes, the case study provides some takeaway lessons. Further research into ketamine as a potential treatment for stammering would be valuable, but the second suggestion that people with a stammer should be screened for depression because a drug that treats depression and has been found to reduce stammering in one person is not logical or ethical. Unless a person with a stammer presents with or reports symptoms of depression, why would a health professional assess them for depression? Having read the article and listened to me critically appraise it, how do you feel about it now? Did you agree with my ratings or would you have rated anything differently? I'm now going to share my personal thoughts about the piece and offer suggestions about how I think it could be improved. I personally think it is a very interesting case study. The difficulty comes with how to actually apply this sort of evidence to clinical practice. Speech and language therapists do not prescribe drugs, so they may not read a case study where the main treatment is delivered by another professional. The doctors who are most likely to prescribe medication for depression work as general practitioners in the community and have limited day-to-day contact with speech and language therapists, and I imagine are unlikely to read this article as part of their normal professional development. Where I see this article being applied to clinical practice is perhaps in a more specialised multidisciplinary setting such as mental health, where doctors and speech and language therapists work more closely together. If I had a patient with a stammer who was also depressed, I would send this article to the psychiatrist I work with to see what they think. In terms of how the piece could be improved, I will give a few examples. First, the whole structure of the case study could have been improved to make it easier to read and follow. There was no clear logical flow to the case study, and the authors moved backwards and forwards in time when discussing various aspects of the patient's background, the drug she was taking then stopped, and the impact of her stammer on her psychosocial well-being. Second, the authors did not describe the patient's stammering before she took ketamine. This is somewhat understandable given that she had a developmental stammer and there was no obvious reason to suspect that ketamine would reduce her stammering. The authors, to their credit, attempted to get a baseline of her stammer from a previous speech and language therapy report, presumably after the patient died and they realised the significance of what they had observed. But unfortunately, this request was refused. Now, I don't know enough about the American healthcare system and don't feel the authors provided enough information in the footnote either to make a judgment about whether the refusal to share information was appropriate or not. Having said that, I feel the authors could have done more to attempt to describe her stammering before ketamine was prescribed, and we'll touch on this in the next point. Third, the author's description of the patient's stammer in the month after her treatment started was inadequate. The authors did not make any attempt to collect any objective evidence of her speech or subjective impressions from the patient herself or her family members and close friends about the change in the stammering. I have included a reference on the screen and in the description below to an article written by Sarah Horton et al. Sarah is a speech-language pathologist and PhD student at the University of Melbourne who has demonstrated that there is a strong positive correlation between how speech and language therapists rate the speech of people who stammer and how people with a stammer rate their own speech. Essentially, asking the patient to rate her own speech would have given the authors reliable evidence of the change in her stammering. Alternatively, the authors could have made a referral to speech and language therapy to assess her formally to collect objective evidence of the improvement to her stammer. They might have thought that this was not a high priority given the setting, or did not expect her to die so quickly after the treatment started, given that she had lived there for 5 months already. A simple, easy to implement option given the circumstances would have been to ask the family members and close friends to anonymously rate her stammer before and after the treatment on a scale of 1 to 10, and that would have been an improvement on what was reported in the case study. Fourth, the author's description of the patient's stammer resolving was not just incorrect, as she still presented with symptoms, which were not well described either, but also misleading, as there is no known cure for stammering. Whilst there was an observed reduction in her stammering, I feel the case study should have been more conservative in how it described the changes in her speech, as it is common in this area for treatments to be seen as miracle cures that stop stammering, but the changes are often not permanent and come with significant long-term side effects as well. Finally, whilst I agree with the main take-home message of the case study that there should be further research into ketamine as a possible treatment for stammering, it would have been useful for the authors to give a more concrete plan of what those next steps should look like specifically, especially as the authors acknowledge that the precise pathogenesis is not understood, i.e. they don't know why ketamine reduced the patient's stammer. For example, would they recommend conducting a pre-experimental or experimental case study? If you found this video useful, give it a like and subscribe to receive notifications about similar videos in the future. You can watch other examples of critical appraisal by clicking on the video on your screen now. If you've got any comments, questions, or have a request for other research you would like me to critically appraise in the future, then let me know in the comments below or get in touch with me on Twitter. Otherwise, thanks for watching and take care.